Welcome. We are pleased to have you here for the Grassroots Project webinar. We see 177 folks have joined, and we're so pleased that you're with us. I would like to spotlight the interpreters for you. So just one moment. I'll promote you to panelist interpreters, and you should feel free to spotlight yourselves. My name is Kate Brady. I co-direct the Grassroots Project with Alex Bernardi, who's also joining us. And we could go to the next slide, please. Interpreters are reset. I'm going to make sure that there are captions. I see captions going. And I'm sorry that you can't spotlight. Let's see if we can fix that. Hopefully that worked. Okay, so today's webinar is an overview of HR1, and we will be covering two main topics: the significance for people with disabilities, as well as state-level perspectives and a panel discussion. And we're really excited to have some phenomenal speakers today. We can move to the next slide, please. Some quick logistics for you to be aware of. Participants will be muted during the webinar. You do have access to the question and answer panel if you need to submit questions. And towards the end of the webinar, if time allows, panelists will have an opportunity to respond to questions. We are offering live captions, which can be accessed by clicking the CC button at the bottom of your Zoom screen. Live Spanish interpretation can also be accessed by clicking the interpretation button at the bottom of your Zoom screen. It looks like a world icon. And that button will put you in the Spanish channel. Once you're in the Spanish channel, you'll want to silence the original audio. Se puede acceder a la interpretación en español en vivo haciendo clic en el botón Interpretación en la parte inferior de pantalla de Zoom, icono del mundo. Una vez en el canal español, por favor, silencie el audio original. This live webinar will include polls and evaluation questions, and we'd very much appreciate if you would be prepared to interact during the polling times. Okay, next slide. Thank you. We'd be thrilled to get your follow-up and any feedback that you have about the webinar. You can send those items to grassroots@hsri.org. We don't offer continuing education units, but you will get verification from Zoom of your attendance, and we are happy to provide further verification if you need to reach out to us. We will share the recording of this webinar along with a plain language summary and transcripts on the Grassroots Project website. And those will be available, we think, within a couple weeks. So stay tuned. And thank you to the team for dealing with some tech issues in the background. Let's go to the next slide, please. All right, so quickly, we really enjoy knowing who's with us during the webinar. So I'm going to share with you a quick poll. And this poll will ask you here, and you can respond in as many categories as apply. You might be a person with a disability who uses long-term services and supports or an HCBS waiver. You might also be an advocate or a family member of a loved one of a person with a disability. You could be someone working in a disability organization, a caregiver or staff or supporting a person with a disability. And if you don't want to say, don't know, or find yourself identifying in another category, we'd love to hear about that in the chat. Okay, I'm seeing a great participation. It looks like we have a great many advocates, family members, and people with disabilities here, as well as people working in disability organizations. So thank you very much for your participation. I'm going to go ahead and end the poll. Okay, moving to the next slide. So quickly, an overview of what we're doing today. This is a national webinar on HR1. We will be focusing on how the legislation pertains to people with disabilities. We are hoping for this to be an informational session, and hope that this will support your understanding of the legislation and staying informed. As we know, this policy environment is constantly evolving. We will be lucky to hear from national experts and advocates about the parts of HR1 that have particular significance for people with disabilities. And moving on to the next slide, please. Thank you. We also have a link in the chat for captions if you need them that way. So today's speakers are summarized on this slide as well as in a downloadable appendix on the Grassroots Project website, where you will be able to see everyone's biography. Our first speaker today is Jennifer Johnson from the Administration on Disabilities. We can move to the next slide. I'll turn it over to you, Jennifer.
Hey, this is Alex. Jennifer is still having some technical difficulties joining or rejoining. So what I might suggest is that we move on
Yes,
and note that we have a welcoming from the Administration for Community Living, but that we move on and to our next speaker, and if we can, we'll come back.
sounds great. Thank you, Alex. Sorry she's still having difficulties. So let's keep going. One more slide. So I'll just give you a little bit of information about the Grassroots Project, which is hosting this webinar today. We launched in 2023 with support from ACL, and our goals are to support national, state, and local disability advocates in building networks, growing leadership, all with the intent of driving disability policy and supports in ways that serve disabled people and their communities. Next slide, please. We have two major approaches in the project. One is to develop structures, processes, and relationships that support cross-disability, cross-generational, and culturally diverse leaders within the disability community. And we also are engaged in connecting and growing networks of disability coalitions so that they can support each other in improving disability support systems at the local, state, and national level. Next slide, please. There are a number of key partners critical to the work of the Grassroots Network, many of whom are represented here today. We have a 15 organization National Advocacy and Action Coalition, of which you'll hear from 3 today. We have an advisory state agency partnership group and 10 local coalitions engaged in a state and local Advocacy Coalition cohort. Next slide, please. And if you're interested in the particulars of either of those, you'll find more details in the appendix on the website. And it is now my pleasure to introduce Allison Barkoff from the Hirsch Health Law and Policy Center. She is a policy associate professor and program director at the G.W. Milken Institute School of Public Health, and has a phenomenal legacy of leadership in this space. And we're so delighted to be learning from you today. Allison, turning it over to you.
Great. Okay. And I think you may need to pin me. And can you hear me okay? Okay, great. Thank you again for having me, and very excited to see 230 people who are interested in learning more about HR1 and its impacts on people with disabilities. Let me start by just saying I'm going to talk through kind of three major ways that HR1 impacts people with disabilities, just to make sure everybody knows what I mean when I'm saying HR1. There was a major piece of legislation that was passed this summer and signed into law by President Trump on the 4th of July, named HR1, or One Big Beautiful Bill Act. And that bill has some major changes related to the Medicaid system. Next slide. I'm going to talk through each of them. The first are a set of changes in how Medicaid is financed, and in particular, some changes in the ways that states can come up with their part of the funding for Medicaid services. Medicaid is a state federal program, and there's both the money that comes from the federal government and the match that has to come from states. And I'll talk about what those changes mean in terms of state choices around their home and community-based services program. Still in the vein of talking about home and community-based services, I want to talk about a new flexibility that was part of HR1 in terms of home and community-based services and how that's different than what has existed in the past. And then the third thing I'm going to talk about are new requirements for certain people participating in Medicaid, and that's particularly people who receive Medicaid in states that have expanded Medicaid coverage under the Affordable Care Act, and new work reporting requirements, community engagement requirements, and what that could mean for people with disabilities and their caregivers. Next slide. Okay, so let me start on the first part of my presentation, focused on home and community-based services. Next slide. So I think many of you know this, but just to make sure people understand how critical the Medicaid program is for disabled people. Medicaid is the primary funder for all types of long-term services and supports, and Medicaid funds both institutional services like nursing homes, as well as home and community-based services, the in-home supports and community-based supports that help people get out of bed, that help people shower, that help people in workplaces, and that help people go out into the community. And if you look at the chart that I have here, you can see that there is over $415 billion going into long-term care each year, the vast majority being Medicaid. The split of $131 billion, again, most of that paid by Medicaid. And if you look for home and community-based services, the vast majority, over 3/4, is funded by Medicaid. Most people with disabilities who need long-term services and supports prefer to live in their own homes. And as I mentioned, Medicaid can fund that through a variety of services, and it can provide things like personal care, adult day, respite, habilitation, transportation, and home modifications, all under what's called home and community-based services. Next slide. What's really important is to understand in the structure of Medicaid, that there is what is often called an institutional bias. When Medicaid was created in the 1960s, there was no such thing as home and community-based services. That wasn't created until 20 years later and added on as an optional service. So that means states must provide institutional care. So if someone meets a nursing home level of care and wants to be in a nursing home, for example, a state must provide that service to anyone who is eligible. It is very different around home and community-based services. First, states do not have to offer home and community-based services at all, although every single state does. But what's important is, unlike mandatory services, they can limit the number of people who get home and community-based services because it is optional. And that is why most states have waiting lists for home and community-based services. And because home and community-based services are optional, states have a lot of flexibility about how to structure their program, including the number of people they serve, the types of services, at what level, and the reimbursement rates. Next slide. So with HR 1, there were major changes, and the Congressional Budget Office, which is basically the financial scorekeeper, who looks at what are the costs and what do different bills mean, said that there would be over $900 billion, so nearly $1 trillion in reduced federal Medicaid funding over the next 10 years. And that increases the pressure on states' Medicaid budgets because, as I talked about, state and federal, it's a joint program, and states have to have balanced budgets. So while there is not a direct reduction in funding for any types of long-term services and supports or home and community-based services specifically, the reduced federal funding creates a lot of pressure on how states will manage their Medicaid budgets. And what we have seen is that historically, in the past, when states have tight Medicaid budgets, the place that they usually go, and one of the only places they can go, are optional services to balance their budgets. Next slide. With a set of researchers over the summer, we went and looked at, during the Great Recession from 2010 to 2012, where there was a very similar situation and every state faced reduced Medicaid funding, we wanted to look at how did states respond. And we saw that every single state reduced optional services like home and community-based services in several different ways. Some decreased the number of people that they served. Some decreased the number of hours that they gave to people. But if you look and see, 51 states out of the 50 states and District of Columbia reduced home and community-based services. And disability advocates and disability researchers express similar concerns about what we might see as a result of HR 1. Next slide. So a couple different ways that advocates in working with their states should be really looking at the types of changes we might be seeing from states in terms of policy changes to their home and community-based service programs. Some states, and we are already beginning to track and see proposals come out, some states may try to completely eliminate a particular program or particular services within a program. So for example, a home and community-based services waiver might have 10 services in it, and a state might say, we're gonna take 3 of these services out. As I mentioned, states can have waiting lists. They set a certain number of people that they might serve, and we might see the number of people they serve go down, or put new caps on the amount that they will spend per beneficiary. There could be reductions in provider rates. We could see the eligibility for home and community-based services, and states get to define the level of care, increasing, and meaning it will be harder to enter these programs. We might see in states that have managed care in their HCBS programs, reducing the capitation rates. And we might see policies that for people who are in more individualized supports, that then because of budgeting and staffing reasons, move them into more congregate supports. Next slide. Up, back one, please. And just to mention, we have tracked over time as states have reduced HCBS funding and reduced programs, what that means actually for people with disabilities and older adults who use home and community-based services programs. We may see less people in HCBS programs and longer waiting lists. We've talked a lot through the Grassroots Project and other programs led by the Administration for Community Living about the direct care workforce crisis. And again, reducing those reimbursement rates will mean even less funding to pay direct care workers. We may see a number of families who are having to step in to fill the gaps in services and leaving workplaces. Higher use of institutional care, more people in nursing homes. We may see things like more emergency room visits, and again, more congregate supports over individualized supports. Next slide. Finally, I will mention those are the ways that there are a lot of concerns about impacts on HCBS. I will also mention that over the last several Congresses, there has been a lot of interest in finding new ways to try to expand access to home and community-based services. And there was a bipartisan bill that was developed in the last Congress, and it was added in to H.R. 1. This creates a new flexibility for 1915C waivers, which traditionally have required an institutional level of care and made it really challenging to either serve people in particular with behavioral health needs or people who do not yet meet an institutional level of care. In the statute itself, it requires that if states choose this option, they need to make sure it doesn't negatively impact the waiting list for the traditional 1915C services. And there's some limited funding available to states to implement that authority, which is available starting in 2028. I will mention that, we are trying to track this and that in the short term, again, states will have to come up with their own state match. So it's really unknown how many states will be in a position to take advantage of this flexibility. Next slide. Okay, I will spend then the last couple minutes I have moving off of home and community-based services and talking about a separate requirement called community engagement or work reporting requirements. Next slide. So these are requirements that were added as part of H.R. 1 that apply to all people who are part of the Medicaid expansion population. And by that, I mean the 40 states and District of Columbia that have chosen to take advantage of what was created in the Affordable Care Act to expand Medicaid beyond the traditional population. You might not think of it this way, but more than 20% of the expansion population includes people with disabilities. That might be people with mental health disabilities, substance use disorders, or people who don't meet the very high eligibility standards of the traditional disability pathways. And it's worth mentioning that the Affordable Care Act has actually increased access to long-term services and supports. 1 in 10 HCBS user under 65 and 1 in 5 under 65 who use long-term services and supports do that through the ACA expansion. Okay, next slide. So let me just explain what the requirements are around community engagement. This applies for adults age 19 all the way up until they become eligible for Medicare, the other program that's open to older adults. So 19 through 64, again in states that took up the ACA expansion option. For everyone, you have to either show, and this is to be eligible for Medicaid, as well as to continue being enrolled in Medicaid. You have to show that every month you either have 80 hours of work or community engagement unless the person can prove that they meet an exemption from these requirements. And again, you have to prove you meet this when you apply to Medicaid, as well as there are new requirements that every 6 months for the expansion population, you will have to show that you continue to meet these eligibility requirements. These are nationwide requirements, and every single state will have to implement this by January 1 of 2027. And while the statute, and I will talk briefly, includes some categories of exemptions and what counts, there is not yet specific guidance from the Centers for Medicare and Medicaid Services. We expect that out in June. And I will also note that the statute does allow states potentially to ask the Centers for Medicare and Medicaid Services for more time to implement, but CMS has said that they will, in general, not be granting good faith extensions. And again, I'll just mention that the nonpartisan Congressional Budget Office estimated that over 5 million people who should be eligible for Medicaid will lose coverage, mostly due to the administrative challenges and paperwork requirements through the community engagement requirements. Next slide. So specific to disabled people and caregivers, while this is not a word that I think any of us would have otherwise chosen, but it relates to kind of a category under the Affordable Care Act that was brought in here, and is for people who meet standards for being quote unquote medically frail. And the statute itself lays out a number of people, if you can prove that you meet one of these exemptions, then you don't have to show 80 hours of community engagement. So if you are blind or meet the standard, the very strict standards for SSI or SSDI, for a disability, you have a substance use disorder, you have a disabling mental disorder, and I put that in quotes, that's the statute's language, a serious or complex medical condition, or a disability that significantly impacts one or more activity of daily living. Those are required. There are some other optional ones for temporary exemptions for people who might be in inpatient care, traveling for extended medical care. And there is also an exemption for children under 14, caregivers of children under 14, or caregivers of a person with a disability of any age, with a very broad definition. Next slide. So let me just end by talking about ways that Grassroots can work with your state. I think the challenge is we don't completely know the contours of what states will and won't be allowed to do until we get the details from the Centers for Medicare and Medicaid Services. But within the statute, states are already preparing. They're starting to work on definitions of these exemptions, and it's really important to collaborate in developing the definitions for disability and medical frailty and the caregiver exemptions, and to really make them as broad as possible within whatever limits CMS says. The second is the statute talks about having to verify as much as possible using data. And it's going to be important for stakeholders to work with your state and thinking about all of the potential data sources, whether it's with a managed care organization or claims data. As people are applying for Medicaid, working with your state on the applications to try to flag for the state and for applicants people who should be exempted. And then again, within the guidance that comes from CMS, allowing self-attestation, meaning saying, I'm a caregiver, I care for my adult child with a disability, and allowing that representation to count. Finally, there are within the statute options on how the exemptions work. States will have choices about how long an exemption can continue, and maximizing that will be really important to minimizing the red tape. How far back states look to have you been in compliance in order to even get into the program, And then states must redetermine at least every 6 months, but can do it more. The more often there are redeterminations, the more red tape and administrative burden there is. Next slide. And I will just end by saying that it's really important for grassroots and partnerships, whether it is centers for independent living, aging and disability resource centers, protection and advocacy agencies, state councils on developmental disabilities, the many behavioral health organizations and the university centers on excellence and developmental disabilities. All of you and the grassroots program here are going to be critical in working with your state. And with that, I will turn it over to Sarah.
Thank you, Allison. We are so pleased to have you and thrilled to move to Sarah Swanson.
Yeah. Hi,
Thank you,
everyone.
Sarah.
Can you hear me okay?
We can. Thank you so much.
Okay, let me turn my camera on. It is so nice to be here with you. I am a white middle-aged woman wearing a bright colored top with long curly brown hair, and I'm wearing glasses today. And I'm here to share how HR 1 is currently or will be impacting states. Next slide. So here are some general facts we know about HR 1. It's the largest cut of federal funding to the Medicaid program in its history. It creates a 20% reduction in federal funding to the Supplemental Nutrition Assistance Program, otherwise known as SNAP, and it changes how some states finance Medicaid. One of the realities is it shifts more costs to the states. Next slide. This is a timeline for some of the major changes required in HR 1. The Medicaid work requirements that Allison just discussed in the expansion group will go into effect by the end of this year. Funding changes to Medicaid and the SNAP programs will begin in 2028. Next slide. Medicaid is a partnership between the federal government and each state. There are mandatory benefits, and then there are some benefits that are optional for states to offer. As Allison mentioned earlier, home and community-based services is an optional service. I've listed some of the other optional benefits states can decide if they want to cover. These include providing dental care, dentures, eyeglasses, physical therapy, occupational therapy, personal care services, etc. Unfortunately, when states' budgets get tight, they must find ways to reduce their budget. Because these are optional Medicaid benefits, these are the services that often get cut first or are eliminated altogether. Next slide. Unfortunately, we are already seeing cuts or reductions to Medicaid and Medicaid home and community-based services, and the full requirements of HR 1 has not been fully implemented. Next slide. Idaho is one of the first states that announced cuts to their Medicaid program. According to the Idaho Governor's Office, the changes to state and federal tax cuts under HR 1 is estimated to cost the state $155 million this year and $175 million next. Two articles from the Idaho Capital Sun are featured on this page. One article indicates that the Idaho governor just approved $22 million in disability budget cuts, and the other article indicates that a 4% cut is proposed to Medicaid providers. There are concerns that providers will not take Medicaid patients and provider agencies may close. Additionally, the state will be working to move their home and community-based services to Medicaid managed care organizations, with full implementation expected in 2029 or 2030. Listening sessions are happening now and offer opportunities to be engaged in the design and have your voices heard. Next slide. Last month, the Colorado's Joint Budget Committee voted to make cuts to Medicaid and reduce services for those with developmental disabilities to help fill a massive budget cut. The committee recommended capping the weekly paid hours of family caregivers to 56 per week. Next slide. I've included snapshots of two articles from North Carolina. In October 2025, North Carolina reduced provider reimbursement across Medicaid providers between 3 and 10% to keep funding in line with what was approved by the state legislature. Now, the state is trying to determine how they're going to fund the administrative costs required under H.R. 1 for determining Medicaid eligibility twice a year as opposed to once a year in the Medicaid expansion group. North Carolina DHHS leadership indicated they estimated it will cost $31 million each year to hire staff just to do this extra annual Medicaid eligibility review. Next slide. Oregon's Medicaid program was running over budget prior to the passage of H.R. 1. As a result, lawmakers have been scrambling to identify other funding sources or identify ways to cut services. Now, to comply with H.R. 1, Oregon health officials will also need to fund more than $200 million to implement new Medicaid eligibility rules required and major technology upgrades to implement them. Next slide. H.R. 1 requires states to limit retroactive Medicaid coverage from 3 months to 1 month in the Medicaid expansion group and to 2 months in the other Medicaid groups. Nebraska leadership was proposing to get rid of all retroactive Medicaid coverage by using an 1115 Medicaid waiver. Hospitals, clinics, and advocates have been concerned how this could impact NICU babies, people with disabilities, and the medical system in the state. The picture on the left is a tiny baby in the NICU with the title, Nebraska seeks to end retroactive Medicaid coverage. Hospital leaders say it will have a disastrous impact. Earlier this year, Nebraska also proposed to put caps on personal care services and individual budget caps to individuals who receive support in the state's Medicaid aged and disabled home and community-based waiver when they renewed the waiver with the Centers for Medicare and Medicaid Services. The article on the right features advocates at the state capitol. The headline says, "Families urge lawmakers, DHHS, to stop Medicaid waiver caps for Nebraskans with disabilities and the elderly." I'm happy to report that last week, the Nebraska legislature passed legislation that stopped the removal of retroactive Medicaid. Additionally, after many stories from families and individuals being featured in the news sharing how cuts and caps to the aged and disabled Medicaid waiver would negatively impact them, individuals working with state leadership and state representatives, the Nebraska governor reversed the decision to make cuts to its aged and disabled Medicaid waiver. Next slide. In New York, a group of about 75 different organizations have come together to create a vision for their Medicaid program. The plan includes home and community-based services. New York is expected to lose billions of dollars in Medicaid funding, and hundreds of thousands of people are at risk of losing their public health insurance coverage. Working with others is a proactive way to help influence decisions, and having a unified voice and momentum with lots of people and organizations working together helps to influence policy. Next slide. Advocacy works. Working with others strengthens your impact. Your work educating your representatives, telling your story about the importance of Medicaid and Medicaid home and community-based services is critical. Working in groups and coalitions makes it helpful so that no one person or organization stands alone. I've heard from some advocates who are afraid that they are advocating too much or too loudly, and they are scared that they may be targeted. Working in groups or with organization makes your voice become one of many. Next slide. Last month, disability advocates in Alaska celebrated a universal changing station being installed in the state capitol. The Key Coalition, a group of people with disabilities, their caregivers, service providers, and others, are now working together to create legislation for universal changing stations in all state and local buildings. Working in a coalition and with others has impact. Next slide. It is important to be involved. If you've never attended a public meeting, you should. If your state is making changes to a program, they often host listening sessions. Attending these is one way to stay connected to what's happening in your state and meet others who have the same interests as you. Anytime your state renews or changes their Medicaid home and community-based services waivers or creates a new one, they must take public comment. This is a perfect time for you to share what is working in your waiver or share what is not working with state leadership. Next slide. Another way to be involved is to serve on state committees and councils. In every state, there are federally funded programs which require advisory boards and/or committees that must have representation by people with disabilities and their families. Consider applying for one of these boards or committees. It's a great way to stay current in disability policy and meet others who are working in the field. For example, in state independent living systems, there's the SILC, or Statewide Independent Living Council. There's Centers for Independent Living, also known as SILS. And in the state developmental disability programs, there's the Council on Developmental Disabilities, there's University Centers for Excellence in Developmental Disabilities and Disability Rights. And within state Medicaid programs, they are required to have Medicaid advisory committees, also known as the MAC, and beneficiary advisory councils, known as the BAC. Within the traumatic brain injury programs, there are TBI state partnerships. As I mentioned earlier, states must have a MAC and a BAC to help share feedback on the state's Medicaid program. The BACs are new, so your state may be looking for applicants to serve on this council. The BACs include people who receive Medicaid and have lived experience. These were created to help elevate the voices of those who receive support from the Medicaid. These are great places to bring questions and concerns you've encountered or things that you are happening to others. Go ahead, next slide. And one more slide. For individuals who serve on your state MAC and BACs, you can ask your state leadership specific questions. As Allison indicated, right now your state is deciding how they're going to identify those who are not required or exempt from work requirements in the Medicaid expansion group. They're also deciding how they're going to confirm who is exempt and how they will define the term medically frail. If you don't know these questions, you should ask. These are important decisions for people with disabilities who get Medicaid coverage. Even if you aren't a member of the MAC or a BAC, you can attend these public meetings. Next slide. It's important to develop relationships with state leadership. If things are going well, thank them for that. If there are concerns with changes being made, please share your concerns. If you don't know your Medicaid director or your developmental disability director or other leaders, you should. Serving on boards and committees offers a great way to do this. Next slide. At the most basic level, you should know the name of the programs in your state. Medicaid programs and home and community-based services waivers have names that are different in every state. Some states have multiple waivers. Other states may only have a couple. State Medicaid programs are called different things. For example, Nebraska calls its Medicaid program Heritage Health, and Oklahoma calls its program Sooner Care. One of the most important things is that you know the name of the Medicaid program and the waiver that is important to you. If you don't know, you should ask. And I will turn it back.
Thank you so much. Expert and brilliant as always. I'm pleased now to welcome our discussion panel, which includes Ben from ME Action, Aaron from NACDD, and Jessica from NICL. We'll put those acronyms in the chat. And thank you three for being with us. We have some questions for you, the first of which is could you share with us what elements of HR 1 are you anticipating that will most affect communities you serve? And please also describe the networks that you are frequently interfacing with. And why don't we just go laterally? Ben will go to you, then to Aaron, and then to Jessica. Does that work? Go ahead, Ben.
Great. Thanks, Kate. So all the elements that Allison and Sarah covered so well in their presentations, I think are really important to us. At ME Action, we're especially focused on Medicaid work requirements and how the exemptions for medically frail individuals are defined and implemented by states. That's because for millions of people living with chronic illnesses like myself with ME/CFS and long COVID, trying to comply with work requirements given our severe energy limitations would actually worsen our illness and may cause permanent harm to our health. So there's a real risk of having our healthcare terminated even if we're too sick to work. You see this with those in infection-associated chronic conditions like ours who have long-standing barriers to obtaining accurate disability determinations and functional capacity assessments, especially when we need it most, when we initially lose our jobs or after becoming too sick to work. Now, HR1, as Allison covered, explicitly says that serious or complex medical conditions are a qualifying basis for medically frail exemption from work requirements. But the question is, how are we defining what is serious or complex? And that's something we're paying a lot of attention to at the federal and at the state level. I'll share that just in the past few days, I had a case of a person with ME/CFS. It was so severe. They're functionally dying right now because of an inability to eat. And when they had tried to get care in their state, they were forcibly removed from home and put into a psychiatric institution because they weren't believed or understood. So for me, this example really underscores the extent of the challenge state health and human service agencies face when they can't recognize and support someone with a chronic illness like mine that is literally dying. I think it's going to be really a huge challenge to get them to accurately recognize medical frailty across the full range of conditions and functional impairments that people experience. So it is a big, serious challenge, but I think it's important to start by acknowledging who often gets overlooked in some of these processes, so that we understand the true extent and try to find ways to solve these problems and get people the care they need.
Thank you, Ben. And Erin, same question to you.
Well, I'm really excited to be here. Thank you, HSRI and ACL, for having this. When we're looking at the broad impact of HR1, the historic cuts to Medicaid, and everything that Allison and Sarah laid out for us, the DD councils, the state councils on developmental disabilities, which I represent, are really not a stranger to this issue and are uniquely positioned to lead a systems redesign under HR1. For those of you who don't know, state DD councils are in every state, as well as the territories and District of Columbia. 70% of our members are people with developmental disabilities or immediate family members who've been appointed by their governors. So they sit in a very privileged position and are a part of a lot of these conversations that are happening right now at the states on how to implement this new HR1. DD for us means individuals who develop a disability before the age of 22, and they require lifelong or long-term individualized supports. They are going to be involved in Medicaid in many instances for their entire life. So you can see how any Medicaid funding cuts through cost shifts to the states or any administrative changes in HR1 can severely disrupt these lifelong services. The elements of HR1 that we are particularly concerned about fall into three main categories. Number one, as the panelists talked about, this historic Medicaid federal funding reduction is going to increase fiscal pressure on state budgets, pausing critical work that the state councils have been doing to rebalance our Medicaid services away from that institutional bias that Allison talked about and towards individualized supports in the community, which is what our council members fight for every single day, and what the Supreme Court decision under Olmstead reinforced not so long ago. We are concerned, but we are in a good position. As you heard from Sarah, many of the state DD councils do advocate and educate their state legislators who may not be familiar with HCBS and have been educating for reductions in harm. And although we can't stop every harm that is seen in state budget pressures, we do take a lot of pride in where there are those pressures, educating the members of the legislature that they are informed when they make those decisions. The second thing that we're really worried about is Oh, by the way, Congress categorically rejected that people with developmental disabilities would be impacted by HR 1. They did. We spoke to many members of Congress who said, look, we have broad exemptions. Everything's going to be fine in the states. Now that we're not seeing that really play out, many of us were concerned that maybe there would be some changes. The value of your advocacy and the DD network advocacy is becoming more and more apparent. Second, this law introduces administrative complexities that Allison talked about. We are encouraging our self-advocates to continue to document, register their stories, and if they do lose services, to open a case with their members of Congress and their state legislators to get to the bottom of what changes have been made and how can we fix those changes to get them the supports and services that they need. We have to build a case that if there were any unintentional reductions in services or in eliminations, that we give Congress and state legislators the opportunity to fix those. Because we really do believe that disability is not a partisan issue and that it absolutely involves a lot of very strategic thinking from both sides of the aisle. Finally, we are really excited that HR 1 provides a potential expansion opportunity for those who don't meet institutional level of care. As Allison said, a very important part of HR 1 expanded the option to the state to provide waivers for those folks who do not quite meet an institutional standard of care, which is usually a requirement for the waivers for Medicaid home and community-based services. Now, as Allison also mentioned, the chances of states being able to opt into those is heavily dependent on their fiscal. But if we don't opt into them, we are missing a huge opportunity to show to Congress and to the states that we do believe that people should have more choices and that we do need to intervene sooner so that people are not driven to institutional levels of care needs before they can continue to live in their community and thrive. Thank you.
Thank you. That's good.
Jessica.
Thank you.
Hi, everyone. Thank you so much to the Grassroots Project for hosting this discussion today. So from the perspective of the Independent Living Program, the elements of HR 1 that we are watching the most closely are elements that will impact or change how core benefit programs that provide crucial benefits for people with disabilities like Medicaid and SNAP function on the ground. So the IL program is really uniquely positioned to be the impact people. So for those of you who don't know, the IL program is also a national federally funded infrastructure that's embedded in every state and territory that's designed to support people with disabilities to live independently in their communities. So we have our statewide independent living councils, or SILCs, which are similar to the DD councils, also governor appointed. And they focus on statewide planning, priority setting, and monitoring the implementations of the state's independent living plan. And then we have Centers for Independent Living, or CILs, which are local consumer-controlled nonprofits that provide direct cross-disability services such as benefits counseling, information and referral, peer support, advocacy, and transition from nursing home settings, which is really important, one as it relates to HR 1. And really that infrastructure is really unique to really identify in real time as individuals with disabilities are coming to CILs for services, how some of these changes are impacting and what barriers people are experiencing, to then have that information translate up to our state level advocacy and be informed in our state plans. So changes that affect eligibility, renewals, work reporting requirements, or any administrative processes are likely to increase demand for assistance with navigating benefits, managing paperwork, and for IL core services. So we're really being mindful of how these changes are also affecting state budgets and are really uniquely positioned to provide both that local disability-led and statewide disability-led voice to the impact of this issue so that hopefully we can help mitigate harm and work with partners all across the community. So we serve folks of all ages from childhood through end of through 112 or older, and really uniquely poised to work with both aging and other disability stakeholders.
Jessica, thank you.
I'm talking really fast, trying to keep you.
You did a great job, and you gave us just the last 2 minutes to wrap up. with genuine thanks to our three panelists from Emmy Action and ACDD and Nickel. We did have two other questions I know you prepared responses to, so we will share those out with your review as well as the questions that are in the Q&A that we didn't get to. So we really, really appreciate all the audience engagement. Let's go to the next slide, please. Thank you, Meredith. Please get in touch with us at grassroots@hsri.org. We will make the PowerPoint deck as well as a recording available on our website in a couple weeks. Let's go to the next slide. So, we would love your feedback on this webinar. In fact, it would be very, very helpful for our funding to get your honest response. The link is on the screen and we've shared it in the chat. You'll also receive an email. It is a very, very brief survey. Won't take you more than 10 minutes. Thank you so much to our brilliant speakers, to Allison and Sarah and Ben and Erin and Jessica. We're grateful for your partnership. And thank you to all the advocates who joined us today. We hope you have a wonderful rest of your day. Take care now.